Welcome all to the today's session. So today we continue with the endocrinology module, and today's topic is a calcitonin, parathyroid hormone, vitamin D, and the calcium. Okay, so these are the very frequently asked questions in the MRCOG Part 1 examination. So first we'll see about the calcium in the blood. Okay, so what is the normal level of calcium? It is the 9 to 11 milligram per deciliter, and it is present in two forms. The ionized form, that is around 5 milligram per deciliter, which is the active form. So active form is the ionized form, and it is around 5 milligram per deciliter. The second form, which is an inactive, that is a protein bound calcium, that is around 4 milligram per deciliter. And it is also present in a complex form, that is a maybe phosphate complex or citrate complex. Okay, that is around 1 milligram per deciliter. Okay, so there are three forms: active, which is ionized calcium, then protein bound, which is inactive, and there is another which is a complex, that is around 1 milligram per deciliter. Okay, so ionized is around 50%, which is active, protein bound is around 40%, that is inactive, and complex form is around 10%, but it is diffusible. Okay, then from examination point of view, you should remember this ionized calcium, that is the physiologically active. Okay, now how this calcium is absorbed. Okay, and what is helping the, we know well that it is the vitamin D which is helping for the calcium absorption, that is the calcitriol. We say vitamin D is a calcitriol. See, here it is a, in from the blood we are getting this calcitriol, it goes into the intestinal cell. So this calcium will bind with the calcitriol will bind with the receptor. There is a vitamin D receptor. So calcitriol increases the calcium absorption. So this calcitriol will bind with the receptor, will form the calcitriol receptor complex, and this complex will then form the binds with the this calbidin will be formed. Okay, so this calbidin further is acting as a transport medium for the calcium. The calcium is coming from the lumen into the cell, and this calbidin is responsible for the transport of this calcium. Okay, so what are the factors regulating the calcium? It is the vitamin D or the calcitriol. So this vitamin D, for vitamin D also there are questions which are asked. So in the skin you have 7-dehydrocholesterol, which is getting converted into cholecalciferol. In the liver, it there is a hydroxylation forming the 725 hydroxylation. Then in the kidney there is a 1 hydroxylation that is forming the calcitriol, which is the active form. So from the skin it goes to the liver, and the final is in the kidney. Okay, so what is the action? So action of vitamin D in the intestine, it increases the calcium absorption via calbidin synthesis. Okay, then in the bone it increases the osteoblast activity, and it increases the mineralization via increased phosphate concentration. In the kidney, it increases the reabsorption of the calcium and phosphate. Okay, so and another action is there by increasing the clothoprotein. This is specifically in the distal convoluted tubules of the kidney. Increase in the clothoprotein, and these are the channels for the calcium absorption, TRPV5 and TRPV6. Okay, so that increases the reabsorption of the calcium from the kidneys. Okay, so this is also this action in the kidney of the reabsorption of the calcium via clothoprotein. Okay, and that via these channels are there. Okay, so from examination point of view, calcitriol is not same as calcitonin. Calcitonin is different. Calcitriol is your vitamin D. Okay, calcitonin is a different hormone. Okay, so vitamin D increases the calcium, and it also increases the phosphate. Okay, now we go ahead with the next hormone, that is parathyroid hormone. So again, this is the SBA, which cells will secrete the parathyroid. So these are the chief cells of the parathyroid that secrete the parathyroid hormone. The active form is the first 35 amino acids. Normal level is around 10 to 60 nanogram per liter. It is controlled by the ionized calcium. So there is a negative feedback mechanism. So ionized calcium is the active form. So that will give the negative feedback. That is how it is controlled. Okay. So receptor will increase the cyclic AMP, that will lead to the kinase activation. So parathyroid hormone will increase the osteoclast activity, and it will also cause the bone resorption, and it will increase the calcium in the blood. Okay. So in the kidney, it will increase the calcium reabsorption, and it will decrease the phosphate reabsorption. So increase excretion of the phosphate. Okay, so it will decrease the phosphate reabsorption, and it will increase the phosphate excretion. While vitamin D, what does it do? It increases the calcium absorption and it also increases the phosphate absorption. Okay. So here in the kidney, this parathyroid increases the calcium reabsorption, but decreases the phosphate reabsorption. So increase phosphate excretion. So in the intestine, it increases the calcitriol synthesis, leading to the increased calcium absorption. Okay, PTH will increase the calcitriol synthesis, will lead to the calcium absorption. Okay, so in summary, parathyroid increases the calcium and decreases the phosphate. Okay, so this you should remember. Now let's come to the third hormone, that is calcitonin. Okay, and what is the source of this calcitonin? These are the parafollicular cells of thyroid. Okay, parafollicular cells, also called as C cells. This is also SBA. Okay, what is the source of calcitonin? Parafollicular or C cells of thyroid will secrete this calcitonin, and it is stimulated by the increased levels of the calcium. Okay, so what is the action of this calcitonin? So it will act on the bone, it will reduce the osteoclast activity, and it will increase the osteoblast activity. Okay, in kidney it will increase the phosphate excretion. So in summary, calcitonin will decrease the calcium. Okay, so key hormone controlling the calcium metabolism, parathyroid will increase the calcium, calcitriol will increase the calcium, and calcitonin will decrease the calcium. Okay, and there are certain additional regulators such as phosphorus. There is an inverse relation with the calcium. So normal calcium to phosphorus product is 40. Okay, around 40 calcium to phosphorus product. Then serum proteins. So if there is a decreased albumin, there will be decreased total calcium. And it is the ionized calcium remains normal, that because of which there are no symptoms. Okay, so what happens if there is a decreased albumin, there will be decreased total calcium, but still the patient can be asymptomatic because the ionized calcium is normal, which is the active form. Okay, then what is the pH effect? If there is alkalosis, there is a decreased ionized calcium, that will lead to the symptoms. Okay, so we have seen the effect of the albumin is different, effect of the pH is different. In the pH, what happens if there is alkalosis? The ionized form is reduced, so there will be symptoms. In acidosis, ionized form will be increased. Okay, then coming to the renal threshold. Renal threshold is around 10 milligram per deciliter. Above this, calcium will get excreted into the urine. Okay, now coming to the hypercalcemia. What is hypercalcemia? That is serum calcium more than 11 milligram per deciliter. The causes of hypercalcemia are primary hyperparathyroidism, malignancy, bone diseases such as multiple myeloma, metastasis, Paget's disease. Then features will be, there will be osteoporosis, fractures, punched out lesions. Okay, lab findings will be, there will be increased levels of calcium, decreased levels of phosphate, and increased alkaline phosphatase activity. Okay, then complications, there can be renal stones, ectopic calcifications, pancreatitis. Management, IV saline, then furosemide, steroids, and you have to treat the cause. Okay, now coming to the hypocalcemia. Hypocalcemia is a calcium level less than 8.8 milligram per deciliter. Severe deficiency or severe hypocalcemia when it is less than 7.5 milligram per deciliter, that will lead to tetany. Okay, so causes, one is a vitamin D deficiency. It may be because of low sunlight, malabsorption, or liver disease or kidney disease. Second is hypoparathyroidism. It may be related to the surgery or autoimmune condition. Then other causes such as renal failure, that will increase the phosphate. Then hypomagnesemia, alkalosis, pancreatitis. What will be the clinical features for hypocalcemia? In neuromuscular, there will be tetany, muscle cramps, paresthesia. Okay, and there will be Chostek sign and Trossus sign. Chostek sign is a facial twitch on tapping, and Trossus sign is a carpopedal spasm with BP. Okay, ECG will show prolonged QT interval. Okay, that is very typical of hypocalcemia. So lab findings will be decreased calcium, increased phosphate, and urinary calcium will be reduced. Okay, so management is oral calcium plus vitamin D. In severe cases, you give IV calcium gluconate. Okay, so from examination point of view, vitamin D deficiency alone does not cause tetany. Okay, because calcium is only mildly reduced. Okay, now evaluation of the parathyroid function. So test is a serum calcium phosphate, that is the basic screening. Then parathyroid level, that is the confirmatory. Then you have UDTA test, There will be prolonged recovery in hypoparathyroidism. Then there is a TRP test, that is decreased reabsorption with parathyroid. Then calcium load test, there is a decreased PTH normally. Okay. So comparison of action of three major factors affecting the serum calcium. Okay. So you have vitamin D, you have parathyroid, and you have calcitonin. So blood calcium is increased by the vitamin D, while it is drastically increased by the parathyroid. Okay. In calcitonin will reduce it. Main action of vitamin D is from the absorption of the gut. Okay. These are the SBAs. Then PTH is mainly the demineralization, and calcitonin opposes the demineralization. Okay. Then calcium absorption from the gut is increased. Here it is increased, but it is indirectly increased. Okay. Then bone resorption, it is reduced. In PTH, it is increased. In calcitonin, it is reduced. Okay. Then deficiency manifestation will be rickets if there is a vitamin D deficiency, while parathyroid deficiency will manifest as a tetany. Okay. Then use in the rickets, vitamin D is the drug of choice, while parathyroid, uh, it is a contraindicated. Okay. Then this in calcitonin is theoretically beneficial in the rickets. So rickets, vitamin D can be used, but the parathyroid is contraindicated. Okay. Calcitonin theoretically beneficial, but the main drug of choice will be vitamin D. Then effect of excess, there will be hypercalcemia. Here also there will be hypercalcemia, and here there will be hypocalcemia. Okay. So these are the hormones which are controlling the calcium. So that finishes this particular topic. Thank you. Doctor, we have few questions. Can you please go through these questions and solve?
Yes, sir. A 55-year-old woman presents with recurrent renal stones and bone pain. Lab shows increased calcium level, decreased phosphate level, and increased PTH level. What is the most likely diagnosis? Vitamin D deficiency, primary hyperparathyroidism, hypoparathyroidism, calcitonemia, chronic kidney disease. Sir, option B, primary hyperparathyroidism.
Yes, it can be primary hyperparathyroidism because there is increase in calcium, decrease in phosphate, and there is an increase PTH level. Okay, so primary hyperparathyroidism, classic triad is there. So increase calcium, decrease phosphate, increase PTH. Primary hyperparathyroidism. Usually it is adenoma. Okay, renal stones and bone resorption are typical. Next.
A patient with hypocalcemia develops carpopedial spasm after BP cuff inflation. What is this sign called as? Sir, option C, Tournier sign.
Process sign. Correct. Okay. So increasing BP cup leading to carpopedal spasm, that is a process sign indicating hypocalcemia. Next.
Which hormone directly increases the calcium reabsorption in renal tubules, which while increasing the phosphate excretion? Sir, option C, parathyroid hormone.
Parathyroid hormone. Okay. So parathyroid increases the calcium reabsorption and decreases the phosphate reabsorption. Okay. So it causes phosphaturia. Next.
Patient with chronic kidney disease develops hypocalcemia. What is the most likely mechanism? Increased calcitonin, increased intestinal calcium absorption, reduced calcitriol synthesis, increased PTH sensitivity, increased albumin binding. Sir, option C, reduced calcitriol
Yeah,
synthesis.
reduce calcitriol synthesis because final stage of hydroxylation happens in the kidney. Okay, so the first is in the liver, second is in the kidney. Okay, so kidney failure will lead to reduced one hydroxylation, leading to decreased calcitriol, leading to decreased calcium absorption, leading to hypocalcemia. Next.
Which of the following is the primary action of calcitonin? Increased intestinal calcium absorption, increased intestinal calcium absorption, increased osteoclast activity, decreased bone resorption, increased renal calcium reabsorption, increased vitamin D activation, sir, decreased bone resorption. Option C.
Primary action of calcitonin
Calcitonin.
is the
Decreased
decreased bone
bone.
resorption. Okay, calcitonin inhibits osteoclast, leading to decreased bone resorption, leading to decreased serum calcium. Next.
A malnourished patient has low total calcium but no symptoms of hypocalcemia. Total calcium but no signs of hypocalcemia. What explains this? increased ionized calcium, increased calcitonin, increased phosphate level, increased PTH, increased vitamin D. Sir, increased ionized calcium level. Option A.
A malnourished patient has low total calcium, but no symptoms of hypocalcemia. There are no symptoms, but the total calcium is low. That means ionized calcium will be either normal or it should be increased. No, that is the increased ionized calcium. Okay, because hypoalbuminemia is there. So decreased total calcium, but ionized calcium remains normal. So no symptoms. Next.
Which condition is most likely to cause tetany despite normal total calcium levels? Which condition is most likely to cause tetany despite normal total calcium levels? Acidosis, hyperalbuminemia, alkalosis, hyperphosphatemia, hypermagnesemia. Sir, option C, alkalosis.
Alkalosis, right. So alkalosis increases calcium binding protein. So decreases ionized calcium leading to tetany despite of normal calcium. Next.
A child presents with rickets, which mechanism is primarily responsible? Increased osteoclast activity, decreased calcium absorption from intestine, increased calcitonin secretion, increased phosphate excretion, increased renal calcium loss. So decreased calcium absorption from intestine, option B.
Correct. Decreased calcium absorption from intestine. Okay, vitamin D deficiency, there is a decreased calcium absorption, defective mineralization leading to decrease. Next.
A patient has hypercalcemia with low PTH levels. Which of the following is the most likely cause? Parathyroid adenoma, vitamin D deficiency, medullary thyroid carcinoma, hypoparathyroidism, and malignancy with bone metastasis. Hypercalcemia. Hypercalcemia with low PTH level. Which of the following is most likely? Hypercalcemia with hypoparathyroidism, sir?
I think it should be malignancy with bone mets. Malignancy with bone mets because non-PTH mediated hypercalcemia is there, no? So PTH is suppressed. There will be bone metastasis that will lead to increased calcium release. Next.
Which of the following best describes the action of vitamin D on bone? Only inhibits osteoclast, only increases calcium increases, promotes mineralization via osteoblasts, decreases phosphate levels, inhibits collagen synthesis. Third option C, promotes mineralization
via osteoblasts. Okay, vitamin D leads to increased osteoblast activity, increased phosphate, bone mineralization. Next.
A patient with hypoparathyroidism is given EDTA. What is the expected finding? Rapid normalization of calcium, prolonged hypocalcemia, increased phosphate in excretion, increased calcitonin, increased vitamin D. Sir, option B, prolonged hypocalcemia.
You are giving EDTA that will lead to the prolonged hypocalcemia. EDTA chelates calcium. So in hypoparathyroidism, recovery is delayed 6 to 12 hours. It is prolonged in hypoparathyroidism. Next.
A patient has hypercalcemia and elevated calcitonin levels. A patient has hypercalcemia and elevated calcitonin level. What is the most likely diagnosis? Hypercalcemia and elevated calcitonin. Parathyroid adenoma, Graves' disease, medullary carcinoma of thyroid, Hashimoto's thyroiditis, vitamin D toxicity. Elevated calcitonin. Option B, Graves' disease.
It is the medullary carcinoma of thyroid. Okay. So calcitonin is secreted by C cells. Okay. So elevated in medullary thyroid carcinoma. That is the tumor marker for this. Okay. Medullary carcinoma of thyroid, calcitonin is a tumor marker. So take home message. Parathyroid hormone increases the calcium, decreases the phosphate. Vitamin D increases calcium, increases phosphate. Calcitonin decreases calcium by osteoclast inhibition. Okay. Ionized calcium, clinically important. Alkalosis will lead to tetany by reducing the ionized calcium. CKD, chronic kidney disease, will decrease calcitriol leading to hypocalcemia. hypercalcemia plus increased parathyroid hormone, that is a primary hyperparathyroidism. Okay, then hypercalcemia with reduced PTH will be seen in malignancy. Okay, so ionized calcium is the active form. Parathyroid will increase calcium, will reduce phosphate, vitamin D increase calcium and phosphate, calcitonin will reduce calcium, alkalosis will reduce ionized calcium and titany, hypoalbuminemia will cause low total calcium but normal ionized calcium. Okay, so no titany there. Okay, hypercalcemia will lead to the stones, bones, and groans. Titany, two signs, Chostek sign and Trausus sign, and severe hypocalcemia will lead to the QT prolongation. So that finishes this particular topic on calcitonin, parathyroid hormone, and calcium metabolism. Thank you.